Okay, so we're live now on Facebook. I want to welcome everyone for this, the fifth day of awareness on GI cancers, which is um, being held by Paras Hospitals in Gurgaon. And today is a very special day because we are joined by a lot of illustrious clinicians. Here we have with us Dr. Rajneesh Monga, who's the chief of gastroenterology at Paras Hospital and hepatology. We have Dr. Sanjay Dhawan, who's the director of radiology, chairman and director of radiology at Paras Hospital, Gurgaon. We have Dr. Aditi Agarwal, who is a senior radiation oncologist with us, and we are very, very happy to have all of you here with us today. And our intention today is uh, to to spread information about how we can protect ourselves from liver cancer. So we have discussed about colorectal cancer on Monday, and then gallbladder cancer on Tuesday. On Wednesday it was stomach cancer, and on Thursday we discussed that's yesterday on pancreatic cancer. So today we have a panel with us which is going to discuss about how we can understand what liver cancer is and even understand what the liver is, the function of the liver is, how we can protect other diseases from coming into the liver. And that will really help us to live a more healthy lifestyle and, uh, you know, generally protect ourselves from this cancer. So first, before we just move on to the finer details, I want us to all understand what the liver is. Now, we must understand that the liver is the largest internal organ in our body. So it lies behind the ribs on the right side. So basically, there are two lobes, the left and right lobe. And for surgeons, we look at it as 8 segments, but that is more scientific. So what does the liver do? Its function is to basically break down and store nutrients, something called metabolism, and it also makes clotting factors. So if the liver is not functioning, we have a higher chance of bleeding. It also absorbs nutrient. It helps to absorb nutrients through a juice it produces called bile, and it helps to break down a lot of toxins, including alcohol and drugs, uh, into the blood. So it's like a filter system, which is very, very important. So you can understand that the liver is very important, and there is nothing that can substitute the function of the liver. We have dialysis machines for the kidney. We have a ventilator for the lung, but there's nothing really for the liver. So it's a very, very important organ. So today we'll be there. There are two main types of liver cancers. One is cancer that originates within the liver, so that is the starting point of the cancer, and the other is cancer which starts from some other organ and then later on goes on to spread either through the blood or some other means into the liver. But today we'll be discussing hepatocellular carcinoma, which is the main type of liver cancer we want to focus on today. So move on to Dr. Rajneesh Monga, who will be speaking to us about the risk factors. So we know that a lot of things influence our chances of getting this cancer called liver cancer. But one of the most important factors is hepatitis or chronic viral hepatitis, either hepatitis B or C. And there are many other types of hepatitis or even cirrhosis that can cause it. So the natural pattern is hepatitis, cirrhosis, and then cancer. But to get a better understanding, we'll ask Dr. Monga to share his experience about how he has been tackling patients with liver cancer and what he feels is the way the risk factors that he has experienced with this patient. Dr. Monga, please. Uh,
So, see,
let's
liver
hear
cancer
from
is
you.
one of the common cancers which we encounter. So, any disease of the liver which goes on for more than, say, 6 months or so leads to liver becoming more stiff. So, as liver has a very strong healing power, so it tries to heal itself, but each episode of healing leads to some bit of scarring. So, scarring further leads to a risk of cancer. And the three main causes for liver cancers in the Indian setting is hepatitis B, which is prevalent. It is 3 to 5% of Indian population has hepatitis B. Then the second most common cause of predisposing factor for is hepatitis C, and the third most common, which is growing over the last decade or so is non-alcoholic steatohepatitis, which is related to increased fat in the liver, that is fatty liver. So these are the three main factors which predispose ones to cirrhosis. And there are strict protocols to follow when you have hepatitis B, C, or any form of cirrhosis, and you follow certain protocols, so you pick up liver cancers early. So these are the main risk factors. The other risk factors would include alcohol abuse, things like diabetes, exposure to chemicals, exposure to steroids. So these are the other common factors which lead to increased risk of liver cancers. So
Right.
over
So
back to
yeah, thanks. Thank you, Dr. Monga. And yes, that's very well explained. And it's funny to know that certain toxins in our grains like rice, wheat, and corn called aflatoxins can also lead to this cancer. And even anabolic steroids like what we inject, especially for bodybuilders and so on, that they use have been shown to be predisposing to this cancer. Now, the question we want to ask is, can we prevent liver cancer? So most of the cancers that we have been talking about are not preventable. We can only decrease the risk and we can detect it early. But in liver cancer, why it's an interesting topic is most liver cancers can be prevented. So obviously we can avoid and treat hepatitis B and hepatitis C infections. And there's a surveillance that can be done after that, which we'll get to in a minute. We can limit alcohol or avoid alcohol and tobacco use altogether. Get to and stay at a healthy weight, which is for all cancers across the board. We can also limit exposure to chemicals, and we can treat diseases like hepatitis and other liver diseases, which can go on to form liver cancer. Now, now coming to before we go to the surveillance, I want to ask Dr. Dhawan, who's with us. Uh, so there are a lot of tests which are done in imaging. So we have the simple ultrasound. We have what's called fibroscan, which Dr. Monga can also elaborate. We have CT scans. We have MRI scans. We have PET scan. Now, I suspect that I have something wrong with my liver because I have some pain or I feel there's not good digestion. What test would you recommend for simple for a person who just comes to you, and what is the rationale behind you asking preferring that particular radiological investigation for that patient, for that person? Dr. Dhawan, please.
Yeah, thanks, Vinay. So
Yeah.
I think that's a very good question. And the first thing is that there is no radiological investigation, which is kind of, one-stop shop. Every investigation has to be tailored for a particular disease, particular stage of a disease. So if I talk about detection of early liver cancer, first, I think, annual health checkup, which consists of at least an ultrasound of the abdomen, should be done, because that is where you can detect the risk factors like fatty, like non-alcoholic hepatic steatosis, or any other mild abnormality of the liver outline or something, which would help us suggest that there is possibility of a liver disease. And if the patient is already symptomatic, again, we would like to start with ultrasound. If ultrasound should reveal a focal lesion, then depending on the nature of the lesion, we would suggest a CT scan or an MRI, right? And
Dr. Dhawan, just a brief interruption. So suppose you have done an ultrasound and you feel the patient has fatty liver. When would you advise them to get a fibroscan?
so that is actually the decision about the clinician. We will report
Right.
fatty liver, we would report grades of fatty liver, and the clinician, taking into account our ultrasound report as well as the risk profile or clinical symptoms, would suggest a fibroscan. So
Right.
that would be dictated by that.
So,
Yeah.
so I'll just come back to you with for the CT and MRI. So we'll go to Dr.
Sure.
Monga to ask when does Dr. Monga, when do you recommend a fibroscan for your patients when you're suspecting or confirmed fatty liver?
So a person who presents as fatty liver on a routine checkup normally has also undergone a liver function test. So the fatty liver can be of two types. One is a plain simple fatty liver with a normal liver function, and the other one is liver function are deranged. So when a person has deranged liver function and on clinical examination the liver seems to be firm and you have obesity, and so then you advise a fibroscan. So not all fatty liver patients will require a fibroscan. So fibroscan is basically to check for the stiffness of the liver. So you can imagine that liver is normally as soft as your cottage cheese or paneer. So as you keep the paneer or the homemade cheese out of the refrigerator for a while, it becomes stiff. So similarly, when the liver becomes fatty, it becomes a little stiff. So normally the ultrasound cannot pick up that stiffness. So that stiffness is picked up on the fibroscan. So that is not indicated in all fatty livers. So fatty livers with some bit of inflammation or patient who's had fatty liver for more than say 10 to 15 years and fatty and other high risk profiles like obesity, presence of bad diabetes. So these are the patients who would require a fibroscan.
Right. So since this fatty liver is becoming more and more prevalent in our society, I think it was very important information that has been spoken by Dr. Monga. Now coming back to Dr. Dhawan, uh, so now I've done so I'm a patient with hepatitis or cirrhosis, and then I've done an ultrasound, and there's a doubt, there's a lesion that you can see in the liver. Now, the clinician might recommend a lot of things like a CT scan or an MRI or a PET scan. Can you please tell us what are the pros and cons of each of these tests, CT and MRI, and what is the process? Is it a very elaborate process getting a CT scan for the liver or MRI? What is it dangerous to us? Is there too much radiation by getting these scans, or is it something that we can just feel relaxed about to get these scans?
Yeah, so before I answer your question, we recommend ultrasound like a part of an annual examination because ultrasound is absolutely harmless. It does not involve any radiation. It is just echo of sound waves which are transmitted by the transducer. So it is 100% safe. This is the fact which should be well known to all people, all the common people in the society. Having seen a focal lesion on the ultrasound, as your question is, then we have to see actually what is that lesion likely to be. Is the lesion likely to be benign like an abscess or a hemangioma, or there is a possibility of being a more towards cancer, which we can also judge by serum alpha fetoprotein levels. So the current recommendation as per the latest guidelines is to prefer a contrast enhanced MRI over a contrast enhanced CT for elaborating on the diagnosis of a suspected liver cancer. So that is the absolute current guideline. CT is also useful, but not to the extent of MRI. The difference between CT and MRI is that CT requires it's a radiation emitting investigation. Although the current scanners are very good and this radiation exposure is limited, but then these patients are also likely to get repeat scans in the future because of nature of disease. So to limit the radiation dose, MRI is an absolutely radiation free investigation. So with the safety profile of the investigation with respect to patient is very high. So, but nonetheless, the current recommendation, all the international guidelines are in consonance that for liver cancer, for staging as well as detection, MRI is placed above CT scan.
Great. So that was useful information, and most useful to all of us would be that an MRI does not have any radiation. So even if you have fear of radiation, which is actually not very base fear with a base, but still you can go for MRI, and that is the best test for for liver cancer especially. Uh, Now coming to back to Dr. Monga. So you get many patients with hepatitis and cirrhosis coming to your OPD daily. So do you have any screening techniques for them? Do you get any tests like an ultrasound or tumor markers for them at some regular intervals to see if their liver cirrhosis is transforming into cancer at some point? Because that seems to be something important.
So any patient of liver cirrhosis has to undergo three sets of investigations. First is to assess the liver function, so whether the liver is working all right or not. Second is to look for the portal pressure, that is endoscopy, to see if there are varices or not. And the third, more important thing is relevant to the topic is that every 6 months, any patient of cirrhosis has to undergo ultrasound for screening and a blood test called alpha fetoprotein, which is a tumor marker. So any serial rise in alpha fetoprotein or any detection of a small lesion on the ultrasound is an indicator to further investigate. So without fail, any patient with hepatitis B, C, fatty liver must undergo a ultrasound and an alpha fetoprotein test every 6 months.
So, any of your patients with hepatitis B or C, have you seen them getting cured, or have you seen them kind of becoming seronegative, what we call after your treatment?
See, the aim for treatment for hepatitis C is cure. It is possible to clear the virus. So, treatment of hepatitis C has undergone a revolutionary change over the last few years. But hepatitis B, the target for or the aim of treatment is to suppress the virus for a long time. So it is not clinically possible in the current scenario to clear the hepatitis B virus. So even if you suppress the virus, the risk of cancer goes down, but it doesn't become zero. So the process of surveillance needs to continue in any form of cirrhosis, even when you have suppressed the virus or even when you have treated hepatitis C. So any cirrhotic, whatever you do for treatment, you have to continue the screening process.
Right. So what we have learned from this session so far is that what Dr. Dhawan has said, and now what Dr. Monga is saying is, you should be taking care of your liver. So if you feel there's any problem with your liver, you should be consulting a gastroenterologist or hepatologist, and being in tune with what is happening to your liver, getting an ultrasound, like Dr. Dhawan mentioned, a regular health checkup. If there's any issues, your clinician will tell you to get a fibroscan if there's fatty liver. If there's hepatitis or cirrhosis, then we should not be afraid to get CT scan or MRI scan as mentioned, because it's very safe and it's very effective at diagnosing these diseases. So with that, we'll move on to just the next section, which is how do we know that we might have liver cancer? We're talking about cancer here. So this is not very specific to liver cancer, but some of the signs and symptoms are weight loss of appetite, nausea, vomiting. Sometimes we might vomit blood, as mentioned. There could be, your clinician might feel something under your ribs, which might be the liver or spleen, and there might be abdominal pain. You might have jaundice, which means yellowing of the eyes and skin, and sometimes yellow urine, and they might also be itching. So those are some of the signs and symptoms. So just because you have any of these signs and symptoms does not mean that you have liver cancer, but this could be a warning sign. So it's important that you take note and consult someone relevant, especially a gastroenterologist. So now we'll come to the treatment. So we have, thank you, Dr. Monga and Dr. Dhawan. Thanks for joining us. And we won't want to take any more of your time. And we really appreciate you coming on and giving us your valuable inputs.
Thank you very much.
Thank you very much to both of you. Now we have with us Dr. Aditi, who is a radiation oncologist. So I'm very happy to have her here with us, because a lot of us know about treatment for liver diseases and especially liver cancer. We've heard about surgery. So in surgery, a person like me will say that we will remove maybe half or more than half of your liver, whichever side, the left side or right side, or even more than that left or right side, or maybe a part of your liver where the cancer is. And that will be the best form of treatment if detected early, especially if you're in consultation with a gastroenterologist to detect it early. But if there's in a background of cirrhosis, that means if the entire liver is already damaged, and if you're detected to have liver cancer, the best option would, and it's all the diseases confined to the liver, it's not spread beyond the liver. The best treatment option might be a liver transplant. So we won't be talking too much about a liver transplant, but there are two types. One is when we do a disease with somebody who's donated the organ to you, or someone who's a living donor can give a transplant. So that is an entirely different topic. But we might have heard of targeted therapies, something like people mistake for chemotherapy, but it's something usually tablets that we take to
Dr. Vinay, we can't
suppress
hear
this
you.
cancer, control this cancer. And there are many interventional radiology techniques. That means we can insert or infuse chemotherapy or radiation therapy through the hepatic artery, much like how we use for cardiac procedures. And then that the entire chemotherapy or entire radiation goes into the liver and helps to shrink or control the cancer. But what many of us don't know much, even many physicians or clinicians don't know much, is that now there's an increasing role of radiation therapy for liver cancers. And that's why we have with us Dr. Aditi, who will speak about how radiation can be helpful in liver cancers. Dr. Aditi.
Yeah, thank you, Dr. Vinay, for the question. So, as you said that most of the times in early detected cases, the treatment of choice would be surgery. So, taking it out would be the best thing. And transplant, yes, if it is possible. There are few patients where surgery is either not feasible or the patient is not fit to undergo surgery because of the size of the lesion or the medical comorbidities that the patient has. So there actually radiation has a very important role to play. And also for patients jahan pe lesion is very big and as a bridge to transplant. So we can combine the interventional procedures of infusion of that chemotherapy, which is called TACE, along with SBRT, which is a very precise form of radiation where we give high dose of radiation per sitting in 5 or 7 sittings. So the total treatment can be completed within a week or 10 days. And the size of the lesion does decrease. So the local control rate is as good as 70 to 80%. 25% of the patients can have complete response and 60-65% would have partial response. Really good response rates with a treatment that is not invasive at all. It is absolutely painless. You just have to lie down in a machine which looks like a CT scan machine, and the treatment can be done very simply within 10 to 12 minutes. With the advancement in radiation, this SBRT has really evolved because now we understand that treatment can be delivered to very high doses in a very precise manner. Initially, that was not possible because liver moves with respiration. So target localization was not very accurate. So dose delivery was not possible. But now, yes, with the advancement in these techniques, it is very much possible.
Great. So thanks, Dr. Aditi, for explaining about radiation. So before we move on to Dr. Vibhor Sharma, I want to ask Dr. Monga one more question. So suppose you've diagnosed a patient with liver cancer. How do you decide, and you feel that the cancer can be removed? How do you decide which patient will go for like a liver surgery or liver resection, and which of them would you recommend to get a liver transplant, provided that all the financial situations and everything are okay? How would you decide that?
Is that question is for?
For you, Dr. Monga.
Sorry, I missed that audio.
So the question is,
How do you decide whether?
suppose you detect a patient with liver cancer which is localized and you feel it's operable. In which patients would you recommend them to go for a resection? That means just removal of part of the liver. And which patient do you think you'd recommend them to go for a transplant?
So you basically have to decide on the basis of two things. First is the liver function. So if the liver function is good and the lesion, the second thing is the size of the lesion. if the size of the lesion is small and the liver function is good, so then you do a local therapy. Send the patient to the surgeon for a liver resection, because the rest of the remaining liver will tolerate the surgery and the patient will not decompensate after the surgery. So a good liver function and a small lesion, direct surgery. If there is a bad liver, a small lesion, then a transplant. A large lesion which is only confined to the liver, then you have to either do some reduction and then think of resection, or directly think of a transplant. So the two factors will decide. One is the size of the lesion and the other one is the liver function. So
Yes,
here comes the importance of picking things early. So if you have a lesion which is small, then it is resectable. So for a liver cancer to be symptomatic, it has to be a large lesion. So that is why you should screen your patients early, so your modalities can pick up. Imaging modalities are so good, they can pick up lesions less than a centimeter also now. So that is the right approach: screen and then aim for a resection, and if not possible, then maybe transplant.
I think that's beautifully and very simply explained by Dr. Monga. So, in addition to what we mentioned, we also have techniques like local ablation techniques, like frequency ablation and uh, microwave ablation, which can burn small tumors, maybe less than 3 or 4 centimeters. We can burn them, especially if the patient is not a candidate or not fit for undergoing a major operation like a liver resection or other surgery. So that is another treatment option. I think we have Dr. Vibhor who's joined us now from medical oncology. Dr. Vibhor Sharma is a medical oncologist with us, and we will ask Dr. Vibhor now, what are the systemic therapies that you have? By systemic, I mean what are the targeted therapies, or do we give chemotherapy in liver cancer or immunotherapy? What is, how do you manage patients with liver cancer who come to you?
So thank you, Dr. Vinay. So as already discussed by all the previous speakers, that most of the patients of liver cancer that we are seeing in our country, especially, present with a very advanced stage. So at most of the times we find that they are unfit for the surgery, and liver transplant is also a costly procedure. Some patients do get a transplant, but many of them cannot afford. So the practical options are mostly local regional therapies, which you have already discussed, and systemic therapy. So as a medical oncologist, till a few years back, medical oncologists had only one drug to give, that is sorafenib tablets, and there was nothing else to give. After sorafenib progression, there was nothing that we could do, and the patient was just put on supportive care. But now, because of recent advancements, multiple new therapy and immunotherapy, so now they're being superior responses. Plus, there are immunotherapies like MAP and atezolizumab, monoclonal antibodies like bevacizumab. There are combinations in which these drugs can be used. So the take-home message for the listeners is that these days the systemic therapies in liver cancer have progressed a lot, and it is not the time when we are only having one option of sorafenib. We have multiple options of targeted and immunotherapy and monoclonal antibodies with which patients can be treated, and the future lies in using these therapies early and making the unresectable patients or untransplantable patients transplantable with the use of these therapies. Thank you.
So,
therapy we do not use in liver cancer most of the times.
Right. So I think Dr. Vibhor has very clearly explained how we can use drugs to treat liver cancer, and how unfortunately most patients who come to us, especially in our country, are advanced and uh, either have to go for systemic therapy, like he has mentioned, or a combination of therapies, be it local therapy along with systemic therapy. So the take-home messages for today, before we conclude, I'll just brush past everything. The first thing is to keep our liver healthy by maintaining a healthy lifestyle. We can avoid certain things like excessive alcohol or alcohol in general, and tobacco, and also certain chemicals and certain toxins. And then we can uh, keep ourselves in touch with a gastroenterologist if we have hepatitis or cirrhosis, so that we can see that it's not progressing to something more ominous or more dangerous like liver cancer. And then we understood the signs and symptoms, how we can understand if we have something like that going on. And we've understood a bit of treatment, which is quite complex, but we have many options for treatment. It's not like there are no treatment options. And so with that, I hope that most of you have benefited from hearing about liver cancer, and you're now more aware with all this information. And we're happy to have you with us for these last 5 days in which we have discussed GI malignancies. And I hope you'll join us next week for the next session from the oncology department here at Paras Cancer Center in Gurgaon. Thank you very much for your attention, and we look forward to uh, um, meeting you again soon. Thank you, Dr.
Thank you.
Aditi and Dr. Vibhor.
Thank you.
Thank you.